of today's ward work was stealing.
OTD gave exactly what it was supposed to. Surgery vlog. Oh my god, what are you stopping? Surgery vlog take 10. This is like the 1 million time I'm trying to do this, but yes. Good morning, everybody. This is day 1 of week 3 of surgery rotation. So I'm heading down to the hospital pretty early. So I want to reach early to see about patients before the house officers begin, so we could have some kind of updates to present to them and so forth. The doctors did send us the patient list over the weekend, so I know exactly who we need to see and all that. So yeah, just gonna check up on everybody and do some physical exams and all that good stuff on them before the house officers get there. So yeah, today is going to be a day. Today is going to be a day. That's all I can say. Alright, I'll see you all later. Hey guys, so I am home. I'm actually really tired, so I just want to update you all on the cases that I saw before I take a shower and go to sleep. This morning when I got to the hospital around minutes to 7, I started soaping on some patients that we saw last week. The first patient was somebody who had abdominal carbuncle, and then there was another patient who thankfully stepped down from high dependency unit to the surgical ward. Appears to be doing better. Once we get on the wards, what we do is just we gather information. We take like a brief history from the patient, so we find out all the subjective stuff like how they're feeling, any new symptoms, any new complaints, if they're experiencing, like if they had an infection, if they're experiencing any fever, or chills, any nausea, vomiting, that kind of thing. And then you start checking all the objective stuff, so like the vitals, anything that you notice in their physical presentation. And then you speak about your impressions, like what you think might be going on with the patient based on their diagnosis, based on the clinical findings. You would state your impressions, and then what is your plan for that patient? What would your management be? So what drugs you want to put the patient on, what kind of care, whether it's change of dressing or to start them on a new painkillers or new antibiotics or whatever. Come up with a plan, and then the senior house officers and the registrar and so forth would review your findings and so forth. So that's what we do for our patients. And then after we did our ward rounds, so after we soaked our patients, then the house officers came and did ward rounds, and we had a lot of dressings to be changed and debridements to do today, and cleaning wounds, and just changing dressings and stuff. After that, we went down to accident and emergency for some patients that were referred to us. So we these are new patients coming in, so we have to take like a full history of the patient, do an exam, and then present the history to the doctor, who would then, you know, see the patient and do like an exam to determine what is the plan going forward. So I think today I saw patients that came in with an abscess. Then I saw so many people today, and I actually saw a patient who was set to go into emergency surgery for acute appendicitis. Definitely had the classical presentation of acute appendicitis, you know, the right lower quadrant pain, the Rosing positive sign, I can't remember the other sign, with the obturator muscle, you know, eliciting pain and all that. Yeah, just the typical findings. Yeah, it's pretty cool. It's pretty cool, yeah, seeing everything, and yeah, looking at, you know, just images and blood results and stuff, and just kind of thinking a little bit more clinically about the information that we receive. Like, the house officers on our team are really helpful in that regard. So there's more what we have to do. You kind of have to marry the knowledge that you have with what you're seeing in the hospitals. So at first it might be just a little bit overwhelming, but this is week 3, so we kind of getting more and more used to it, and kind of figuring things out and learning more and more what we have to do and what's expected of us every day. So yeah, that was the fun stuff that we got to do today. Tomorrow is another day. I have to be there for 7 a.m. again, to just round on patients again. And yeah, I believe that we might have clinic tomorrow. So this will be the surgical clinic. So patients who may have been discharged in the past, but just coming for follow-ups and stuff, and maybe new patients who are being referred from like local health centers to surgery for surgical intervention. Those might be patients that we'll be seeing tomorrow. So hopefully, yeah. And yeah, I am really tired, so I am going to take a shower because I have the hospital all over me. So I'm going to take a shower. I don't even think I want to eat. I just want to take a shower and go to sleep. Yeah. Good morning.
Who's that wonderful girl?
Morning, guys. It's day 2. I woke up late because my alarm never went off. Like, literally, I think my phone was frozen, so the alarm never went off. So I woke up late, so I'm late and kind of going through some really bad traffic right now, so I'm going to be really late. But I'm sorry if I rushed through the summary last night. I was just really tired. After I got home yesterday, all I did was take a bath and went to sleep. I didn't eat, I didn't read anything, I did nothing. I just went to sleep. So today, so far we have a pretty short patient list. I think most of the cases we may be seeing today would be in accident and emergency, or maybe clinic, I'm not sure. But we have a pretty short patient list. So hopefully that means that we get to leave early. Wishful thinking, that doesn't happen in surgery. But yeah, I'm tired, I'm frustrated, I'm hungry, but today is going to be a good day. Yeah. Y'all, I swear being a medical student is going to turn you into a klepto.
Like, it's a part of your training. At this point, with working, doing any kind of ward work, you're going to have to learn to steal resources. At least here, because everybody is struggling to have stuff and you're just trying to get stuff for your patients. So you have to do stuff, unfortunately. So I have like just a bag full of needles, cannulas, blood tubes, tape, gauze, gloves, sterile gloves, the full works. You just have to. You have to, because you have to be useful and you have to be helpful when you're on the wards. You can't just stand there doing nothing. You have to participate and you have to be helpful. Your folder need to be filled with forms that patient need to, you know, for referrals, for administering drugs. You just need to have stuff in order to be useful. You just, because we're already getting in the way of the doctors doing what they have to do by us being there. So the least you could do as a medical student is be useful. So you have to have stuff. And in order to have stuff, you have to steal. And the theme of today's ward work was stealing. Yeah. Because we're just so low on gauze. It's ridiculous. I don't understand how a surgical ward could not have sterile gauze. That's like the most necessary thing that you need on a surgical ward, is to have sterile gauze. But it just goes to show how much patients were warded. So how much sterile gauze was needed, or used up, I should say. But yeah, all in all, we saw a wide range of patients today. So some patients that we had met the night before in emergency that were warded. A woman that needed a stoma because she had like a huge hole in the suprapubic area. Really large hole, like to the point that's not too sure, but to the point that it looked like we were close to a bowel. So yeah, like really deep hole. Don't know what's the history and the story behind that, but I guess as we read her file and stuff, you'll get to know more about what happened there. You know, the normal stuff in general surgery you deal with is like diabetic feet. So persons that would have gotten a wound or some kind of infection in their feet and would need debridement, and you know, just cleaning the wound and monitoring it for to make sure that the wound is healing well. For those that were warded earlier, later last week, would be discharged. So you would have patients to discharge by, you would have to do a final inspection of the wound to see how it's healing, if it's healing well and there's no like discharge like pus and you know, that kind of thing, and you see in good healthy flesh being formed, you discharge them and stuff. So that's the kind of thing you would see in gen surg. Of course, you would see did have a patient that got through with their surgery to have their appendix removed, and met them today and they were doing a lot better. Very happy for the gentleman. Blood pressure was coming down and everything, no longer in the kind of pain that he was in last night, you know, with acute appendicitis. It's very painful. So glad to see that he's doing better, and he was in very good spirits when I saw him, as opposed to last night. He's doing a lot better. So yeah, those kind of things you would see patients. Like you saw a patient in clinic this morning for a follow-up after having a cholecystectomy last year, and now pain has returned. And it's a very interesting case because where she had the surgery and where she's experiencing pain now is two very different locations. So this new pain that she's been experiencing may not actually have to do with the fact that her gallbladder was removed last year. So we're waiting to see. I would like to see the progress of where that case goes. I hope to bounce her up sometime next week if she comes back to hospital. yeah, again, just saw a wide range of patients. Had a couple GSWs warded from emergency, got their surgeries and they're recovering and everything. So yeah, all in all, very interesting day, and just being exposed to a wide range of cases, and just trying to learn as much as possible and just try to be as helpful as possible. And I mean, the best thing that you can do is to just go home and read up on what you see, because of the pace of surgery, you may not always get a whole bunch of bedside teaching, not always, right? So you have to just try to absorb as much as I could in the moment and try to learn, especially when it comes to procedures and stuff, learn what to do, how to properly dress wounds, how to debride and stuff like that. But yeah, great day today. Hey guys, so today was actually a really short day. I got dismissed very early, like around 12:30, which is very rare. So it's not something to be expected to happen on a regular basis. So I got to the hospital a little bit late, but I still on time, but I left later than I would like to. Once I got there, I started soaping patients, and then I heard that we had another class, well, a clinic with one of the urologists. So I went to that. After that class, yeah, I went back to do ward rounds with the house officers, and once that was done, they kind of just let us off early and told us, like, we have surgeries tomorrow, go home, read up on these things, whatever, get yourself prepared, walk with your scrubs, all that good stuff. So I just left campus, I came home, I had a good sleep, I had something to eat, so now it's time to work. So now I'm going to read up on everything that we have to read up on. So I think, let me make sure, because I made notes. Let me make sure I have it right. I have to read up on the gallbladder diseases, pathologies and stuff, perianal fistulas, proctoscopy, colon cancer, and stomas. So those are the things I have to look at for tomorrow. So I'm going to do that now. All right. Hey guys, so I'm home. Don't mind the craziness that's going on here tonight. It is what it is. But anyways, so today was our OT day, and OT day gave exactly what it was supposed to give. It was a really, really good day. So we had 4 surgeries today. We had 2 lap choles, a fistulectomy, and a colectomy. So the first lap chole was cholecystitis, and the second lap chole was a cholelithiasis, right? So it's a cholecystitis was the first case, and when they removed the gallbladder, it definitely looked inflamed. Yeah, so we got to examine it afterwards, and it definitely looked bigger than it should look. Although it's a very small organ, when they remove it, it is pretty tiny, but it did look inflamed to me. And the second one was really big. For the cholelithiasis, Once I removed it and we opened it, it was just one single gallstone inside of it, but it was huge. It was huge and it looked like a mixed stone. I don't think it was a pure cholesterol stone, and I don't think it was a pure pigment stone, because pigment stones tend to be very soft. You could like crush them. But this one was really like solid. It was hard. And that one stone was probably causing that patient so much distress. So, once it's removed, I'm pretty sure that individual will feel a lot better. So yeah, it was kind of gross. The second one with the stone is kind of gross because it had like a lot of bile, backed up in it. So once it was removed and everything, you kind of saw all the bile come out and stuff. It smelled kind of funny, but other than that, it was kind of cool. It was kind of cool to see. The fistulectomy was a kind of tough surgery to observe because it's done in a very closed space, because the patient is lying in the lithotomy position. So because of that, it's just the main surgeon is sitting right there front and center, and the other surgeons are kind of around. So it's kind of hard to see, but we did get to see the fistula. Is small but quite prominent, according to one of the house officers. Like usually when they remove fistulas, it's not as prominent as that one. So basically, the fistula is like an extra communication that the wall of the rectum makes with the external environment outside of the anus. So it's like a extra hole. It basically makes like a tunnel to the outside world, the environment outside of the anus. And during the surgery, she was describing the track of the fistula. It's like that fistula was like traveling all over before it came down to outside of the anus. It was traveling all over because I think one minute she described that it was going through like the external sphincter, going and then going cranially. So it was going through the external sphincter, then going up, and then went somewhere else. She described, I couldn't really remember every muscle or wall that it hit, but it was like traveling. Basically in my mind I could kind of see like it was like going like that, like out, up, around, and then down. So it was kind of cool to see. So it, because of the track that it made, it was definitely a more pronounced fistula that came out. So basically it's just a sheet of the rectal wall that got excised, and then they would stitch the hole that it made to the side of the rectal wall, and try to repair the muscle and other surrounding tissue and close up the patient. So it's trying to think. So during the surgery, myself and my other classmates, we were trying to think about what could, some of the complications of a surgery like that could be, because you are cutting through the levator ani muscle. So that's one of the pelvic floor muscles that kind of supports, the tissues in the abdomen and the pelvis. So, I was trying to think about like what future like implications to a surgery like that, like what are the risks and the complications and stuff like that. So it was an interesting case, yeah. And the last surgery that we saw for the day was the colectomy. So upon opening the patient, so the colectomy is basically a resection of the large bowel, and based on the notes, it was supposed to be a resection of the transverse colon that they were supposed to do. But upon opening the patient, it was discovered that there was a lot of adhesions on the small bowel. It was like clumped together like a big mass, and they had to like cut through and separate. It was actually kind of cool, to be honest, how it was kind of cool to see. I don't know if I would insert a picture. I don't know if I should insert a picture, but it was pretty cool to see. Like, I mean, it's probably was one of the reasons for the symptoms that the patient was experiencing before the surgery, but it's kind of cool to see. It's like this big clump. small bowel, and you can actually, like, it's amazing to see like how thin the walls of the small intestines was, because when the light hits it, it's like basically see-through. You could like see through the whole thing. Have a risk of rupture because of how distended it was. So it's like, or rupture or perforation. Yeah, so that was kind of cool. I remember too, in one of the lab coolies, I think it was the first one, we actually, while they were trying to remove the gallbladder, you could actually see the peristalsis going on in the duodenum. You literally were seeing it. Like, it was really cool. I was like, oh my god, you can see. I know, and it's kind of cool because, you know, the patient isn't allowed to eat like several hours before surgery, so it's like, it's kind of weird to see it like still working and moving and stuff, even though there's no food in the GI tract at all. So it's like you're literally seeing the peristaltic waves going down. It's like, it's so cool. I'm sorry. But yeah, today was definitely a cool day. And tomorrow, I think it's the audit day, where all the surgical teams go over, it's basically an M&M, a morbidity and mortality conference, where all the surgical teams talk about the mortalities on their team for the week, and they discuss and basically defend their management plan of each case, and they're kind of drilled and questioned by, you know, the consultants and stuff. So that's kind of cool. Like, last week was my first one, because I missed the one the week before. I missed that day because I had some personal things to do. So there's supposed to be another one tomorrow morning, so I can't wait to go to that. I actually kind of find it's kind of nerdy and kind of fun. I like it, so definitely can't wait for the next one tomorrow. So I'll probably give you all a little snippet of how that went, how that goes. Yeah, so.
Yesterday they said that it was not a large organized collection of solid components, not just to aspirate. So the patient remains stable on the ward while still coming down and breathing. So
And I thought I would have been ending the vlog here, but it turns out that I'm on call tomorrow and Sunday. So after the M&M, we did ward rounds and discharged a few patients, and that was more or less it. We were kind of done with that by around 1 p.m. and we got dismissed early today. Yay! So now I am going to read up on bowel obstruction. I have to read up on bowel obstruction and stomas. So I'm gonna just watch a video until I fall asleep because it's kind of late. So I'm gonna, just watch a video or something until I fall asleep and get myself prepared for the day tomorrow. So. Guys, so what was supposed to be a short day turned out to be a long day, and my feet are killing me because I wore the wrong shoes thinking today would be a short day. So yeah, but all in all, it was an okay day. I was expecting today to be more hectic because it's a carnival weekend, but it wasn't so bad. I didn't have any, like, a whole lot of crazy cases in the emergency, so I was really happy for that. But it's still tomorrow, so we'll see how that goes, you know. But all in all, an okay day. So I'm heading home. The doctor told us to read up on PR bleeds, so I'm gonna do that, and then get something to eat and sleep because I am hungry. Really hungry. So yeah.
I begin to.
All right. Just got dismissed for the night. Unfortunately, the last patient that we saw tonight, they have to go into surgery, but we're not too sure when exactly a person is going into surgery, so it might be a while again. So the house officer decided to dismiss us for the night. Yeah. So I am going to wait for my husband. He should be here soon, in like a few minutes. So yeah. But today was another long day, but fascinating day. But this is more or less how surgery rotation goes. Sometimes you'll have early days and sometimes you'll have late nights. But that's how it does be sometimes. But yeah, tomorrow I have to be back out for 7. Yeah, I think that's what the house officer said, 7 tomorrow. Carnival Monday, but Carnival Monday technically isn't a public holiday in Trinidad, so still have to be out tomorrow. So yeah, that's more or less this long week of surgery rotation. That's more or less how it goes, at least at this hospital. That's how it does go. So yeah. Right.
I begin to